Hello?
Is it visible?
Yes, ma'am. Can you see my screen, ma'am?
No. I have shared your PPT.
Acha.
Problem. Just continue. Okay?
Okay, ma'am. Ma'am, but your PPT is not visible.
My PPT is not visible.
Yes, ma'am. For me, it's not visible.
ते काय होतं येड्यात निघायचं तेवढं
नाही पोरांना चान्स सापडतो
Yeah, now it is visible, I think.
Yes, ma'am. It's from my side.
Okay.
Can you see this, ma'am? Is it visible, ma'am?
Yes.
Okay. So, good evening all. Myself, Dr. Achal Jaiswal. I'm from Guru Mishra Homeopathic Medical College, Selgaon. Today, I will be presenting a case of preeclampsia under the guidance of Dr. Tufan Chakravarti, sir. So, preeclampsia is a condition which most of the pregnant ladies most commonly suffer from preeclampsia. Preeclampsia is a condition of hypertension in which blood pressure is more than 140 to 90 mm of Hg, up to 160 to 110 mm of Hg, along with proteinuria,
Scroll
edema.
down the screen.
Yes, ma'am.
Scroll down.
No, ma'am. It's just introduction I'm giving from myself. Is it okay, ma'am?
Yeah. Please continue.
Hello?
Please continue.
Okay, ma'am. So I was saying that preeclampsia is a condition of hypertension. It's with elevated blood pressure, which is equal to or more than 140 to 90 mm of Hg, with proteinuria after 20th week 20th week of pregnancy in previously normotensive and non-proteinuric woman. So I'll start with the case. Here the patient was a 25-year-old, is addressing from Selgaon, Jalna. Her weight was 60 kg. She came with a chief complaint of severe heartburn, which occurred suddenly before 1 to 2 hours. She also had throbbing headache since morning, along with swelling over the ankle since 7 days. Her case history was as follows. Patient was 22-week primigravida. She came with the complaint of sudden severe heartburn, which occurred before 1 to 2 hours and throbbing headache since morning. There is swelling over her ankle, which persists after rising from the bed, and there was no history of vomiting, blurring of vision, seizure, etc. On further investigation, her OBGYN history was as follows. Her last menstrual period was at 15 December 2022, and her expected delivery date was 22 September 2023. She was primigravida with zero preterm, zero living blood, zero no living birth, and zero abortions. She was married since 2 years. In her family history, her mother was suffering from hypertension. On physical examination, her blood pressure was 160 to 100 mm of Hg. Her pulse was 82 beats per minute. Respiratory rate was 20 cycles per minute. and her temperature was 97 degree Fahrenheit. She doesn't have any significant pallor, or there is no icterus and cyanosis. Edema was present over both ankles, and she also has a pain over her epigastric region. My differential diagnosis for the case was gestational hypertension, preeclampsia, and eclampsia. So investigation which I have done for the case was urine test and blood test. In urine test, I found presence of proteinuria and presence of epithelial cells. Blood test which was conducted was kidney function test, CBC, and coagulation profile. Diagnosis was preeclampsia, as for my differential diagnosis of gestational hypertension, patient have proteinuria, and just for gestational hypertension, patient have elevated blood pressure without proteinuria. And for preeclampsia, she have all the pathognomical signs of preeclampsia with elevated blood pressure, proteinuria, presence of proteinuria, and swelling over her ankle regions. And as there is no sign of seizures or blurring of vision or coma, eclampsia was ruled out. This is my PPT. Thank you.
Okay, thank you, Achal. Please be with us for
Yes, ma'am.
next discussion. Yeah. So to discuss this case, today we have expert faculties from modern medicine, Ayurveda, and homeopath. Our first expert is Dr. Sandeep Sonavne. He is associate professor from Gynec department, Dr. Vasantrao Pawar Medical College, Nashik. Dr. Sandeep, please unmute yourself. Yeah. Sir, you are not audible. No. I think your computer voice is low. You are unmuted, but you are not audible. No. Sir, can you try another device? Till then, yeah.
Okay.
Yes, yeah. Welcome, sir.
Okay. Good afternoon, ma'am.
Good afternoon.
Hello. Yes. Ma'am, I got the case history. Okay. So patient from whatever Dr. Achal has presented, I came to know that she is primary gravida. Actually, case was taken in the last year, I think in 2022. So the patient was primary gravida, 22 weeks of gestation with high blood pressure, edema, and throbbing headache. She came in an emergency ward at the hospital. And now, considering her clinical scenario, Dr. Achal thought she could be a case of preeclampsia. Okay. So shall we go through question answer session, or shall I add through my PowerPoint presentation? How do you like to go about it?
Achal, are you ready for question answer session?
Okay. No, these are not, it's not like question answer. We will discuss the case step by step.
Okay.
Okay. So see, what happens now before going through the management part, first of all, we need to have a correct diagnosis. Okay. So to reach the diagnosis, there should be some certain protocols which define the disorder along with the supporting findings through investigations. So while coming to the conclusion at the end of your history, you should have some provisional diagnosis, like clinical diagnosis. So patient who presented with throbbing headache, high blood pressure, could be a case of chronic hypertension as well. Could be a case of, say, renal disorder, or uh, any uh, any disorder which may lead to chronic kidney disorder, which may lead to this kind of symptoms. So obviously in pregnancy, we always keep this diagnosis first in our mind, like gestational hypertension or preeclampsia. So I just want to know further in clinical examination part, body mass index is important. So patient's height, weight, and her weight gain throughout pregnancies, throughout whatever the 22 weeks of gestation, her weight in this particular month or in last 2, 3, 4 months, how much weight she has gained, that is important. Then about clinical examination part, it should end with, say, per-abdominal and PV examination. So unless you mention few findings on per-abdominal examination, we will not come to know about the fetal parameters and the status of fetus, as well as the changes which are seen through PV examination. So so 22 weeks, patient is diagnosed hypertension. And what is in your mind? How would you like to go about this case? Would you like to conserve or would you like to terminate this pregnancy?
Sir, we can conserve the pregnancy.
Yes. Then why you want to conserve? Any what are the favorable points you feel?
So there is no more complication in her pregnancy at the time when she came to the clinic.
Okay. So see, primary gravida with 22 weeks of gestation, there is no question of termination immediately unless you see a severe kind of disease. So you are absolutely right that our attempt should be to preserve the pregnancy, to preserve pregnancy as long as possible. So before going through management part, my slides are visible, ma'am.
Yes, sir.
Yes, sir.
My slides are visible, PPT.
Yes,
Yeah,
sir.
so I would like to go to this slides quickly. So let us start understanding the disease. Why this preeclampsia is so much discussed since long, and we don't have curative treatment modality available even today. So the important part is it preventable? Can we diagnose it earlier? The complications, can complications be prevented? And what are the modalities of treatment? So this is very this carries a huge global burden. Yeah, almost 80,000 to 1 lakh women die every year due to the hypertension in pregnancy. Around 20% of maternal mortality is in India is seen with this type of complications due to hypertension in pregnancy. So that's why this condition is very important. Early diagnosis may save, not only save the fertility, but of course, it will also reduce the maternal morbidity and mortality. Okay, so shall I go through my slides, ma'am? If you allow me, I'll quickly summarize the whole disorder. Then
Yes, sir. No problem.
okay, so hypertension, first of all, to label hypertension, we should follow the few important things. Like if BP is measured on one occasion, then it is not enough. You have to wait for few more hours, like 3 to 4 hours, and again measure blood pressure in sitting position. Now, if it is more than 140/90 on 2 occasions, apart from that, the blood BP apparatus which you use, the cuff size, if patient is say, why I was asking about BMI, if patient is obese, then your cuff size may be a smaller for that particular woman, and that may give you false readings. So that is important. So in sitting position, if you have taken BP in sitting position, then after few hours, again, measure blood pressure in the same position. That BP apparatus, that sphygmomanometer, the mercury level, it should be at the level of the patient's heart. Okay, so our arm at the level should be at the heart. And you should measure the diastolic sound at the end of 5th Koratkov sound. Now this is very important. Why? Because this single reading can change the whole perspective of pregnancy in this particular patient. If she is say 140/90 and if she is 160/100, the management part completely differs here. Though we are going to give antihypertensive, but of course 160 and 100 and above, we should be alert that this pregnancy may need termination if it is of that high level. Okay, so that's why reading blood pressure measurement is very crucial at this in this particular patients. So how this ACOG American classification this classify this disorder into main 4 parts: preeclampsia, eclampsia syndrome. Preeclampsia is again classified into severe preeclampsia and mild variety of preeclampsia. Then chronic hypertension with superimposed preeclampsia and gestational hypertension. So preeclampsia, as you have told me that this is a case of preeclampsia. So unless you have findings which are suggestive of proteinuria, you can't label patient proteinuria. Okay, you can label patient with a preeclampsia. She could be a gestational hypertension. Okay, so we need to see urine protein measurement through various investigation modalities are available. So routinely at OPD level, we do dipstick method. Though it's a crude, but it will give you a rough idea about how much protein loss is there. If it is showing 1+, then it is around 300 milligram per DL of protein loss. We consider it significant. So above one is preeclampsia. If it is 1 or less than 1 or trace, it is gestational hypertension. So most of the time, preeclampsia is associated with thrombocytopenia, impaired liver function. You have not mentioned liver function test. These are very crucial things. Okay, so subcapsular necrosis happens in hepatocytes in cases of severe preeclampsia. That's why we measure enzymes, liver function test, and those are the enzymes which are affected in very early stage of this disease. That's why their changes in their readings will guide you about the severity of disease and further will help in management part also. So impaired liver function, new onset renal insufficiency, pulmonary edema, cerebral or visual disturbances. So patient she had no visual disturbances. I think you have correctly mentioned that.
Yes, sir.
Yeah. So visual disturbances or cerebral edema is something that is considered as a serious kind of disease. Okay. So patient may go in press, or cerebral edema may turn out into hemorrhage, intracranial hemorrhage as well. So chronic hypertension, as the name suggests, this lady might have hypertensions before pregnancy as well, isn't it? We don't know about it. So she could be a case of chronic hypertension. So how to differentiate it? So if blood pressure is seen more than 140/90, after 20 weeks, we will label it as a gestational hypertension, could be a preeclampsia, or if hypertension is noted before 20 weeks or before pregnancy, so you have to keep in mind that this patient could be a case of chronic hypertension. So chronic hypertension before 20 weeks. Again, this chronic hypertension, on first visit, you found that patient is having BP, say 140/90 at 8 weeks of gestation. And again, she had started proteinuria after 20 weeks. So what is this condition? So this is chronic hypertension with superimposed preeclampsia. Patient को तो chronic hypertension था ही, अभी उसको preeclampsia भी develop हो गया, right? So this is again a different condition. Why we are discussing this condition? Because management part differs in each case. Okay. So what is gestational hypertension? It is just a hypertension after 20 weeks. There is no proteinuria seen and there are no systemic findings noted. So this is how we differentiate gestational hypertension from preeclampsia. Why so much fuss about this preeclampsia? Because this preeclampsia, it progresses. So whatever treatment you are giving, antihypertensive or whatever supportive treatment you are giving, the course of disease is not going to change. This all modalities are focused on preventing the complication part of this disease. Okay, so preeclampsia, we know this 140-90 criteria. Apart from that, if you see proteinuria in a 24-hour, so it should, if it is more than 300 milligram, it is supportive finding for preeclampsia. Nowadays, people have started doing this particular test, protein creatinine ratio. Okay, it is more sensitive than 24-hour urine collection. 24-hour किसी patient को बोलेंगे कि 24-hour urine collection करो, it would be a cumbersome to collect urine for 24-hour. Again, the collection of sample and then so many impurities can be noted while sending this sample to the lab. So protein creatinine spot test is available. If ratio is more than 0.3, it is suggestive of preeclampsia. Dipstick का तो हमने discuss किया. If it is more than 1+, it is preeclampsia. Now your patient fits into this thing. BP was around 160 and it is more than 110. So diastolic is very important in gestational hypertension or preeclampsia cases. Okay. So now if you do, what investigation would you like to do in this case? Can you enumerate? You have already mentioned few of them. So first investigation, what you would like to do? Lab test. Hello. Okay. Dr. Achal is there? Fine. So if patient comes to you with this kind of symptoms, first investigation, we will do CBC. Okay. So obviously it will, we will come to know about the hemoglobin and platelet count. So this patient, if they have severe preeclampsia, their platelet counts are always found reduced. So less than 1 lakh from platelet counts will be seen. Then her liver enzymes, mainly SGOT and SGPT, seen raised. The creatinine will be seen more, serum creatinine level. Sometimes this patient presents with pulmonary edema as well. So if patient is found gestational hypertension, so she will not remain a case of gestational hypertension throughout pregnancy. She may progress to preeclampsia, and preeclampsia may progress to severe preeclampsia, which may progress to HELP as well. What is HELP? HELP is hemolysis, elevated liver enzymes, and low platelet count ka syndrome. So these things overlap. You have to be alert. Now she is primi gravida and having this kind of symptoms. So it is more in favor of preeclampsia because we must know the risk factors for preeclampsia. So nulliparity, primi gravida, multiple fetal gestations, age more than 35, chronic hypertension, gestational diabetes. These are all risk factors for preeclampsia. Okay, so what happens at molecular level is again important because our treatment modalities are based on these issues. The first thing is ये जो villus structure है. If you see here, this villus, this is a placental level microscopic picture. This is what is seen in normal pregnancy. This is decidua, this is myometrium. Now this trophoblastic invasion is narrowed here, while trophoblastic invasion is complete here. So when there is incomplete trophoblastic invasion, you will see narrowing of vessels, and that leads to the changes of preeclampsia. Why this happens? There are so many theories: natural killer cells, oxidative stress, genetic factors, and some other factors like SFL, ATS, this soluble FLT gene 1. So these are the factors which play crucial role. So this is how this oxidative stress along with the molecules which are not embryo protective, they damage the fetus, they damage the endothelial lining, they damage the liver, they damage renal glomerular apparatus, and they also cause vasospasm, and this is how it leads to hypertension. Okay, so I will not go in depth of the pathophysiology. We have already discussed it. when are you going to deliver? Now this 22 weeks pregnancy hai, and you have done all the investigations. You found that there is no proteinuria. Patient just had a blood pressure, raised blood pressure, and no other signs and symptoms of severity of disease. So how are we going to proceed with the management part? Any idea about it? So see, all preeclampsia or gestational hypertension patients, we investigate them. First of all, you have to hospitalize this patient, okay, and then meticulous monitoring is required. Monitoring pulse, blood pressure, urine output, then edema part, rise or reduction in edema, and then changes like visual disturbances, ascites. You have to keep watch on all these parameters. Okay. And then you will start antihypertensive medication along with all pregnancy supportive medication like iron and calcium, protein supplementation. Now she was just 22 weeks. Our aim is to continue pregnancy with adequate control of blood pressure. That should be our aim. We will start antihypertensives. Do you know any antihypertensive which we commonly prescribed to our gestational hypertension patients? Yeah, anyone can talk. If someone is listening, you can participate in this discussion.
Yeah, it should be interactive.
Yeah. So
So-
otherwise,
Calcium channel blockers?
yes. So one is calcium channel blockers. Anything else?
Methyl dopa.
Yes, alpha methyl dopa.
Magnesium
Sulfate.
sulfate.
Yes, magnesium sulfate. So nowadays, a drug of choice is labetalol. It's alpha and beta blocker drug. Labetalol is preferred through in severe preeclampsia, and gestational hypertension patients. Okay, so remember this medicine, labetalol. It's a beta 1 and beta 2 blocker. It also acts on alpha receptors. So now, if you start antihypertensive, then again the requirement of the antihypertensive dosage is to be decided through continuous monitoring. The monitoring of maternal as well as fetal parameters monitoring is very important. So how do we monitor the maternal parameters? So apart from the vitals, how are we going to monitor maternal parameters? So blood test. Again, if you see a slight rise in liver function test, you have already started antihypertensive medications. Then you want to know about the progress of disease. Then again, in next week, if you repeat the investigations, you will come to know that patient, whether she is responding to our medical line of management or whether she is still deteriorating further, or does she need one more antihypertensive in that case. So this is how we should go with the maternal monitoring. Now, the fetal parameters are equally important. How are we going to monitor fetal parameters? So first of all, clinical examination is very important. Most of these patients will present with IUGR, fetal growth restriction. So clinical examination, and apart from that, ultrasonographic examination is very important. So USG findings will tell you about the growth of the fetus, the effect of the disease on placental bed, whether any placental vascular compromise is seen there. And then apart from that, whether patients started developing ascites or pleural effusion due to the hypoproteinemia. Okay, so this is how we are going to monitor fetal as well as maternal parameters. Now we have continued this pregnancy. Patient is well settled on labetalol 100 milligram twice a day, and we have reached up to 34 weeks. What are we going to do at 34 weeks? So
Terminate the
throughout,
pregnancy.
yes. So now 22 to 34 is huge period. We can't leave this patient on antihypertensives. We have to keep this patient hospitalized. If BP is well controlled on the lowest dose of labetalol, her blood parameters are showing normal within normal limits, and if the fetal parameters are also showing appropriate growth for that gestation, we will continue this pregnancy. We are not going to terminate this pregnancy, not at 32, not at 34. We will continue this 37 till 37 weeks. But something physiological few changes starts happening at 32 to 34 weeks, and we need to again see this all parameters at this juncture 32 to 34 weeks. Okay, now if it shows that growth retardation is severe, fetal growth restriction is severe, or maternal parameter starts deteriorating, then you can think of termination of pregnancy. Okay, now why we want to terminate this pregnancy? Now if you continue a case of severe preeclampsia, which had a patient who had already developed ascites, pleural effusion, she has started complaining of throbbing headache and developed severe edema, and then her creat is raised, her liver parameters are showing increase in liver enzyme levels, then yes, we have to take a decision to terminate the pregnancy, because after 34 weeks, it has been found that this patient invariably land up in complications. Those are complications related to, say, hypertension, complications related to pulmonary edema, abruptio placentae, disseminated intravascular coagulation, and sometimes fetal demise can be seen. That's why it is very crucial point at 34 weeks, you have to evaluate this patient again, which was settled on your antihypertensive therapy, whether she is responding to medication or whether she is deteriorating. If she started deteriorating, you have to terminate the pregnancy. That is one point. If she is well controlled with the antihypertensive medications, you have just mentioned like labetalol, nifedipine, and yes, magnesium sulfate or alpha-methyldopa. If patient is well controlled on beta blockers, then you can still give a try till 37 weeks, provided fetal lung maturity is attained. So what we do for fetal lung maturity? We give betamethasone or dexamethasone injections. Okay. Okay. So these patients, they present most of the time. These patients, they present with pre-PROM. Okay, labor. They go in preterm labor. Thrombocytopenia is invariably seen in all those severe preeclampsia patients. IUGR is very commonly seen, oligohydramnios, and Doppler studies also start showing few changes. Okay, so route of delivery is also important. It is decided by gestational age, fetal presentation, cervical status, maternal condition, and fetal condition. At 22 weeks, in your case, if BP is not controlled with labetalol, we have added nifedipine. Again, we have seen that BP is not getting controlled on the two antihypertensives. Patient is started complaining of epigastric pain, throbbing headache is still there. Then, of course, irrespective of gestational age, you have to terminate this pregnancy. Okay. So how are we going to terminate this pregnancy at 22 weeks? Can anyone tell me?
C-section.
Okay. Anything else? So the baby, which is not a viable, okay, the survival of fetus is absolutely difficult in this case. Why you want to give a scar to this patient?
Vaginal delivery.
Yes, you can always try vaginal delivery. Yes, cesarean section can also be performed in those cases where you don't want to waste time for giving trial. Okay, so sometimes patient present with acute hypertensive crisis. She is unconscious. There is, say, intracranial hemorrhage seen. Now, in such a situation, you don't want to waste time, because the whole the crux of this management part is the termination of pregnancy, because origin of the pathophysiology is pregnant giving at the level of fetus and placenta, isn't it? So unless you remove the fetus, these changes are not going to reverse. So in a case of severe preeclampsia or eclampsia, preeclampsia complicated with convulsions is called as eclampsia. In those cases, you need to terminate irrespective of gestational age. And if patient is not in labor, you see cervical changes, there is no change at all. Cervix is posterior, it is not open yet. You don't want to waste time. You can take a scar, you can take an incision on abdomen and you can remove it. But if you see patient is still stable on labor table, if cervix is showing some few changes where you can induce her with say misoprostol or sometimes in cerviprime, you can give trial of labor in those patients, of course, with meticulous monitoring. Now, this route is, as we have seen here, determined by gestational age also. So 22 weeks, you can give a trial because fetus is very small. It can come out. Okay. But at 37 weeks, sometimes it is difficult. Okay. Then in a severe preeclampsia cases, you may go for cesarean section also. Now, any operative procedure has its pros and cons. So anesthesia and surgery also pose a risk to such a patients. That has to be considered. Okay, while termination. Okay. Again, and now this 22 weeks ka fetus ka, if you have done an ultrasonography, you found that fetal heart is not there. Still, you want to give a scar to this patient?
No.
Yes. So these are various factors which will guide you on management part. Now, baby is not there. Why you want to give scar to this patient? Okay. Though you can deliver this baby through vaginal route. Okay. Now, in cases of severe preeclampsia, you need to give seizure prophylaxis because these patients, if BP is not controlled on antihypertensives, then patient will have generalized clonic convulsions. We call it eclampsia. So what is the treatment for eclampsia?
Anti-epileptic drug.
So anti-epileptic drugs are the second line of treatment. First of all is magnesium sulfate. So magnesium sulfate is the drug of choice for eclampsia. And if somebody asks you what is the treatment of choice for eclampsia, then what is the treatment? What would be your answer?
Delivery.
Yes. So ultimately, delivery is the treatment of choice. So prophylactic magnesium sulfate can be administered to this patient who are not well controlled on antihypertensives. Magnesium sulfate kya hai? Is it antihypertensive agent? It is not antihypertensive. It is actually, it acts on NMDA receptors and it blocks the neuromuscular conduction. So you can give magnesium sulfate. Okay. It is again given in, there are various regimes like Pritchard regime, Zussman regime. Okay. We will not go into depth of eclampsia. We will stick to our case preeclampsia. So you two drugs which I would like to elaborate here. First is labetalol. It should be the first choice. Always remember when patient comes to you, you should start with labetalol. It is available in oral as well as IV form. Okay. So onset is 1 to 2 minutes. That's why this drug is preferred. And then side effects are hypotension, bronchospasm. Patient आई है कफ लेके उसको पहले से acute asthma का history है. Avoid these drugs. Okay. The mechanism is alpha and beta blocker. So these receptors are also present on the lungs. That's why on bronchus. So be careful. Second, somebody told me about calcium channel blocker. Yes, this is also a wonderful drug, nifedipine. Initially, it was given, people used to give it with the sublingual dose. And evidence says that sublingual dose can cause severe hypotension in this patient. That's why we are not advocating this sublingual route for nifedipine. Okay. It should be given oral. Tablet is to be ingested. it should not be kept below the tongue of the patient. Okay, so calcium channel blocker can be prescribed. Now the complications we have seen: pulmonary edema, and then oliguria, persistent hypertension, disseminated intravascular coagulopathy. They are seen. Now patient अभी 34 weeks में है, तो लेबर में क्या precautions लेंगे हम? Labor room में है patient, and she is 34 weeks. Baby weight is around 1.8, 1.9 kg, 1.7, 1.9 kg around, and then some few prerequisites are to be followed. Patient should be non-ambulatory. Okay, don't ask her to move around. Why? ये पेशेंट्स जो भी हाइपरटेंसिव है, इनको हम बेड रेस्ट एडवाइस करते हैं. क्यों बेड रेस्ट एडवाइस करते हैं इन ड्यूरिंग प्रेगनेंसी? बेड रेस्ट
bleeding.
हाँ हाँ, yes.
So that there is no bleeding.
Okay, so why they, I mean, this, okay. So bed rest is given to this patient because it has been found that glomerular filtration rate increases with bed rest. So तुम्हारा proteinuria है ना, वो कम होता है. Patient will have urinary output would be normal. Apart from that, blood pressure gets stabilized through adequate bed rest. That's why we ask these patients not to do vigorous exercises like अभी जो yoga, ANC classes वगैरह होता है. So this is not for preeclampsia or hypertension patients. Okay. So restrict IV fluids. क्यों restrict करने का IV fluids? Because there is already a extravascular third space loss. Third space loss मतलब क्या हो गया? Protein ही नहीं है vessels में. Proteins, they hold the water inside body, inside the vessel. Now when protein loss is there, ये सब क्या होगा? Vessel के बाहर आ गया. That is third space loss. इसलिए pleural effusion, इसलिए ascites, and that's why patient is having edema. So in those patients, when already fluid overload is there, you will not transfuse IV fluids. So restrict IV fluids. Okay. Why analgesia? Adequate analgesia is important during labor. Why adequate analgesia? Because pain itself will cause rise in blood pressure. Okay, so adequate analgesia is important. Monitoring through partogram, you know it. Partogram nowadays is essential for all the patients who go through labor. Now, prophylactic magnesium sulfate. Magnesium sulfate के बारे में, apart from the use, its use in preeclampsia or eclampsia, is there any other use of magnesium sulfate? Do you know? Okay, so magnesium sulfate is the preferred drug in eclampsia. Apart from it, it has been found, evidence says that magnesium sulfate will have a beneficial effect on fetus as well. Okay, so it prevents intracranial hemorrhage in preterm or those premature babies. So in patients who are preterm, those who are about to deliver, we give magnesium sulfate 1 gram per hour dose. It's a neuroprotective dose for those babies. So remember this very important use of magnesium sulfate. Okay, we will monitor this patient in labor with pulse, blood pressure, urine output, respiratory rate, reflex, and FHR. Why urine output, respiratory rate, and reflexes? Because these are the 3 parameters which are to be monitored when you give magnesium sulfate. Okay, so when urine output is less than 30 ml per hour, then you should stop magnesium sulfate. When your respiratory rate is less than 20 per minute or less than 16 per minute, you should stop. When reflexes are absent, knee-jerk reflexes are absent, stop magnesium sulfate. Because magnesium toxicity is, these are the features of magnesium toxicity. That's why magnesium sulfate, while giving magnesium sulfate, we monitor all these parameters. And then augmentation with oxytocin and artificial rupture of membranes. Second stage may cut short the second stage. Theoretically, they say instrumental delivery should be advocated in all these patients. But yes, you have to keep in mind that applying forces will itself lead to traumatic delivery sometimes. So be careful while applying forceps. And third stage is very important. Anticipate PPH, because in patient में blood loss थोड़ा भी हो गया तो PPH में जाते हैं. Why? Because there is already a constricted intravascular compartment. Already extravascular compartment fluid ज़्यादा है. So there is active management of third stage labor with oxytocin, uterine massage, control contraction. Methargine is avoided because it causes hypertension, it causes rise in blood pressure. Patient is monitored. Postpartum patient को monitoring करेंगे हम 48 to 72 hours. Why this is very important? Because after delivery, patients not only prone for postpartum hemorrhage, there is chance that this patient will develop pulmonary edema as well. Okay, you have to be careful while monitoring these patients. So sometimes, have you heard the term called as postpartum eclampsia? So patients sometimes after delivery also throw convulsions. Be careful while monitoring this patient. Up to 3 days, you have to keep this patient under supervision. Antihypertensives continued most of the time. Mostly this patient, their blood pressure returns to normal by 12 weeks. So 3 months time, blood pressure goes to normal. If it doesn't go to at normal range, what are you going to do? We label this patient as a case of chronic hypertension, and we start antihypertensives to these patients, and we will not stop antihypertensive at all. Of course, patient will be asked to give follow-up. Now, these are the various complications, and I would like to summarize this. You have to keep a criteria for diagnosis. Unless you diagnose this patient properly, whether it is a chronic hypertension, gestational hypertension, preeclampsia, or case of renal disorder, our management part will not be appropriately placed. Okay, so laboratory and fetal assessment part is crucial. Magnesium sulfate has a very important role in severe preeclampsia and eclampsia cases. And timing and place of delivery is important. And there is one point which ma'am had given me, that timing of referral. So referral, now we know it. This is something called as high risk obstetric, high risk case, and then high risk patients. They are to be monitored and managed at preferably at tertiary care institute. If patient is diagnosed as gestational hypertension without any complication, then we can ask patients to give OPD follow-up with adequate antihypertensive and few important instructions written on the ANC sheet. So this is how cases of hypertension in pregnancies are to be managed. This is all from my side. If you have any questions, now this is very vast topic and we can't address all these issues in a single go. If you have any questions regarding investigation, complications, or management part, you can ask.
Sir, thank you so much for detailed explanation of preeclampsia. Please stay with us for question answer session. Now, to discuss Ayurveda part, we have Dr. Prashant Dalvi. He is Associate Professor from Prasuti Tantra and Sri Rog Department, R.A. Poddar Ayurveda College, Mumbai.
Am I audible?
Yes, sir. Welcome.
Okay. Thank you, ma'am. मैं सबसे पहले आभार व्यक्त करूंगा आंचल के कि जिसने आज एक नया टॉपिक अच्छा उठाया है केस डिस्कशन के लिए. उसके बाद में मैं आभार व्यक्त करूंगा डॉक्टर संदीप सोनोने सर, जिन्होंने मेरा पूरा ये कम कर दिया है कि अब जो है कि सिर्फ मेरा ही आयुर्वेद पर्सपेक्टिव उसमें बचा हुआ है, बाकी उन्होंने सब जो पॉइंट्स थे वो कवर कर लिए. तो बेसिकली जो नॉन आयुर्वेदिक पर्सन है उनके लिए मैं बोलना चाहता हूँ कि देयर आर फ्यू बेसिक थ्योरीज ऑफ आयुर्वेदा. आयुर्वेदा के कुछ एक मूल तत्व है, उसमें बेसिक कंपोनेंट कहे गए कि त्रिदोष है, वात पित्त कफ, सप्त धातु कहे गए हैं और उनके मल कहे गए हैं, और इनके कंपोनेंट्स के वजह से पूरा शरीर बनता है. दिस इज द बेसिक आइडियोलॉजी ऑफ आयुर्वेदिक साइंस. तो इसमें जो इक्विलिब्रियम बोला गया है कि दोषों में इक्विलिब्रियम होना चाहिए, धातुओं में इक्विलिब्रियम होना चाहिए, और जो मल कहे गए हैं, जो एक्सक्रीटेड प्रोडक्ट्स है इसके, या तो सुपरफाइन प्रोडक्ट्स है, तो इनके इक्विलिब्रियम पे ही नॉर्मेलिटी एंड एबनॉर्मेलिटी ऑफ द पर्टिकुलर पर्सन डिसाइड होती है। और वो डिसीजन डिसीज है कि इम्बैलेंस है, ये दोनों में हम लोग डिवाइड करते हैं। बैक टू द टॉपिक, हमारे यहाँ सुश्रुत इज अ पायनियर ऑफ सर्जरी, सुश्रुत आचार्य है। उन्होंने गर्भ को एक
Please mute yourself.
हेलो, हाँ, सुश्रुताचार्य इज अ पायनियर एंड फादर ऑफ सर्जरी, एंशिएंट एरा से उनको जाना जाता है। उसमें उन्होंने सिंगल लाइन में इसको डिस्क्राइब किया है कि फीटस इज एन फॉरेन बॉडी टू द मदर्स बॉडी। तो उसे शल्य कहा गया है कि ये शल्य है जो मदर की बॉडी में जा चुका है। तो ये विचार मेरे तरफ से क्यों इम्पोर्टेंट है, क्योंकि एनी अदर टिश्यूज दोज आर ग्रोइंग इनसाइड अ पर्सन, सो वो एडाप्शन का जो चांसेस है, वो एडाप्शन के लिए उसे शल्य कहा गया है कि प्रेगनेंसी ये उसे फ्रूटफुल रहने वाली है या उसके हेल्थ पे वो असर करने वाली है, इसके ऊपर यह गर्भ जो है, ये गर्भ शल्यभूत है या तो नॉर्मल प्रेगनेंसी की तरफ से जाएगा, ये कहना होगा। अब ये डायरेक्ट रेफरेंसेस हम लोग अगर आयुर्वेद में ढूंढने की कोशिश करेंगे कि प्री एक्लम्शिया, एक्लम्शिया एंड एडिमा इन प्रेगनेंसी, ये तीनों सिक्वेंशियल पार्ट्स है जो हम लोग देखते हैं। तो हरित संहिताकार हमारे जो है, उन्होंने कहा था कि उसमें अष्टोपद्रव कहे गए कि अगर लेडी प्रेग्नेंट होती है तो वो गर्भ की वजह से क्या क्या उसमें बदलाव या डिसीजेस गर्भिणी में हो सकते हैं या तो प्रेग्नेंट वुमन में हो सकते हैं। तो उसमें उन्होंने 8 एंटिटीज कहे गए थे। उन्होंने थर्ड जो है वो शोप को कहा है। तो शोप यानी एडिमा, और एडिमा लीड्स टू फर्दर प्रीक्लम्शिया एंड इक्लम्शिक कंडीशंस टू पर्टिकुलर मदर। सो हारित की वजह से तो ये क्लियरली मेंशन नहीं है, नॉट एग्जैक्टली इक्वल टू बट सिमिलर टू कंडीशंस हम इसमें कहा गया है। देन फर्दर मूव ऑन करते हैं, तो इसमें अगर हम इक्लाम्टिक कंडीशन कहे तो इक्लाम्टिक कंडीशन भी सुश्रुतों ने निदान स्थान में एक्सप्लेन किया है कि गर्भिणी आर्दित हो जाता है। और उसमें काश्यप के खील स्थान में, काश्यप जो संहिता है हमारी, उसमें आक्षेपक और अपतानक का यानी कन्वल्जिव डिसऑर्डर्स मेंशन किए गर्भिणी की रोग चिकित्सा में, और उसके लिए वो क्या क्या चिकित्सा कर सकते हैं उसका मेंशन उसमें किया है। कंसिडरिंग दिस ऑल पॉइंट्स, सबने ये कहा है कि एक तेल का भरा हुआ जो पात्र होता है, उसी तरह प्रेगनेंसी की कंडीशन होती है कि अगर हम किसी एक जगह से दूसरी जगह उसको हिलाना चाहे या तो कुछ भी उसमें एडिशन या डिलीशन करना चाहे, तो वो पात्र से कुछ भी छलका ना जाए। छलकना यानी इट्स हार्मफुल टू फीटस और मदर की हेल्थ और फीटस की हेल्थ पे उसका बुरा असर होने की संभावना है। तो जो भी ट्रीटमेंट पार्ट हम लोग करेंगे या तो मैनेजमेंट पार्ट करेंगे, तो उसमें हमें इन चीजों को कंसिडर करना होता है। अब इटियोलॉजी देखी जाए तो मैंने जैसे पहले ही कहा कि प्रेगनेंसी इटसेल्फ पॉजिटिव फैक्टर फॉर शोथ। हम जो आयुर्वेदिक इटियोलॉजी कही गई थे उसमें शोथ के लिए ये जिम्मेदार होता है कि गर्भ ही है। अब अगर दोषिक तौर पे देखा जाए या तो स्रोतस की तौर पे देखा जाए, तो इसमें फिर एक अग्नि की संकल्पना आती है कि जो भी हम लोग खाते हैं, जो भी हम लोग पचाते हैं, तो उसमें जो एंड प्रोडक्ट रेडी होता है, तो उसे हम लोग आहार रस की तौर पे जानते हैं। अगर ये आहार रस ठीक से पैदा नहीं होता है और वो अगर हम लोग कहेंगे कि पूरा के पूरा पका हुआ नहीं है, आधा अध पका होता है, तो उसे आयुर्वेदिक परिभाषा में आम संबोधते हैं। तो ये आमावस्था में चला जाता है। तो ये गर्भ की वजह से जो भी दोषों का इक्विलिब्रियम डिस्टर्ब होगा, उस वजह से अग्नि भी डिस्टर्ब होगा और आम की उत्पत्ति हो जाएगी। और वो जो है वो स्रोतों में, यानी जहां जहां भी हमें खालीपन देखने को मिलता है, वहां पे जाके वो आलेपन करेगा और वो टेम्पररी ऑब्स्ट्रक्टिव पैथोलॉजी डेवलप करेगा, जिसकी वजह से हमें डिसीज देखने को मिलता है। तो इसको भी हम लोग इसके साथ में जोड़ सकते हैं। ये हुई इटियोलॉजिकल फैक्टर्स इसमें जो है। बेसिकली जो आयुर्वेद साइंस जो है वो पॉजिटिव फैक्टर्स के ऊपर ज्यादा काम करता है और प्रिवेंशन के ऊपर ज्यादा काम करता है। पॉजिटिव फैक्टर में सीधे तौर से सारे जो हमारे ग्रंथकार है उन्होंने कहा है कि गर्भ यही पॉजिटिव फैक्टर है गर्भिणी के शोध के लिए। तो जब तक गर्भ ये womb में है तब तक उसमें ये साइन सिम्टम्स दिखने ही वाले हैं। जब तक उसकी डिलीवरी नहीं होती है तब तक ये दिखने ही वाले हैं। और इसलिए उन्होंने इसके साथ में अगर उनके खान पान में या रहन सहन में जो भी चीजें आएंगी उन चीजों की वजह से भी जिसे एडवांसमेंट ऑफ द डिसीज हम लोग कह सकते हैं वो हो जाता है। तो इसमें क्या कहा गया है कि आहार में हम लोग जब आम्ल लवण क्षार या तो हम लोग कर्ड के जैसी कोई चीजें डेली यूज करते हैं, सॉल्ट भी सॉल्टी चीजें हम लोग डेली खाते हैं, तो उस वजह से वो जो चीजें है वो दोषों को दुष्ट करती है। और जहाँ पे भी स्रोतस में वैज्ञानिक कहा गया है वो दीज आर द डिफरेंट एंटिटी और इटियोलॉजिकल फैक्टर्स उसमें कहे गए हैं। तो वो इटियोलॉजिकल फैक्टर्स गर्भ के यहाँ पे जाते हैं और गर्भ और ये इन्होंने किया हुआ आहार जो है या तो खाना पीना जो है इसके ऊपर फिर मल और क्लेद की निर्मित कही गई है। और उस वजह से शोथ यानी उसका जिसे हम लोग विमार्ग गमन कहते हैं, यहाँ पे एक जगह से दूसरी जगह वो चली जाती है और एबनॉर्मल जगह पे उसका बढ़न होता है तो उसे हम लोग शोथ कहते हैं। तो इसके साथ में हम लोग उससे जोड़ने की कोशिश करते हैं। अब मैनेजमेंट के पार्ट पे चले आते हैं क्योंकि बाकी इटियोलॉजी ये कर नहीं सकते। वन पॉइंट इज मिसिंग कि पॉजिटिव फैक्टर में इमोशनल स्ट्रेस जो है, इमोशनल स्ट्रेस को भी आयुर्वेद ने कंसिडर किया है कि अगर ये इमोशनल स्ट्रेस उसके ऊपर है तो वो भी जैसे हमारा त्रिदोष कहा गया उसमें वात दोष की संभावना बढ़ जाती है और ये वात दोष की वजह से ये जो दमनी उपचय या तो शोथ की प्रक्रिया एग्रेवेट हो जाती है। तो अब इस केस के बारे में अगर ट्रीटमेंट मोडालिटी की तरफ हम लोग चले जाते हैं तो सबसे पहले जैसे सर ने बताया है कि वो हार्मफुल नहीं है या तो नेक्स्ट टू एक्लाम्टिक कंडीशंस या तो जो हम लैब इन्वेस्टिगेशन कहे उसकी टॉक्सिक इफेक्ट तक अगर नहीं चली जाती है तो विल कंटिन्यू विद प्रेगनेंसी। अदरवाइज आयुर्वेद शास्त्र ने भी कहा है कि अविषयतु विकारेषु यानी अगर वो विष समान एक्ट होता है गर्भ तो उससे गर्भ से निकालना दैट इज द मोस्ट इम्पोर्टेंट थिंग। ये आयुर्वेद शास्त्र में भी कहा गया है जो कि मॉडर्न साइंस एडवोकेट करता है कि अगर वो टॉक्सिक सिद्ध होती है गर्भिणी के लिए तो उसे इमीडिएटली टर्मिनेट कर देना चाहिए। और द वेज ऑफ टर्मिनेशन सर ने अच्छी तरह से अपने यहाँ एक्सप्लेन किए है। बीइंग आयुर्वेदिक गायनेकोलॉजिस्ट हम लोग एक चीज ये केस में अब पर्टिकुलरली आंचल जायसवाल के केस में चले आते हैं तो ये सीवियर टाइप ऑफ प्रीक्लम्शिया हुआ है। तो सीवियर टाइप ऑफ प्रीक्लम्शिया में हम लोग इमीडिएटली ओनली ऑन आयुर्वेदिक ड्रग्स ये एडवोकेसी नहीं करेंगे। विल कंटिन्यू विद द मॉडर्न मेडिसिन जैसे सर ने कहा है लेबेटोलॉल या तो एंटी हाइपरटेंसिव ड्रग जो है वो करेंगे और उसमें हम लोग एड ऑन थेरी कर सकते हैं। अब जो बेसिक थिंकिंग जो है जैसे कि सर ने कहा कि उसे हॉस्पिटलाइज ही करना चाहिए तो डेफिनेटली वी आल्सो एडवोकेट कि उसको हॉस्पिटलाइज ही करना चाहिए। प्रेफरेबली हम लोग उसे एक सेपरेट रूम में रखते हैं जिसे हम लोग डार्क रूम कहते हैं। तो फुल फ्लैश डेवलप्ड जो भी साइन सिम्टम्स है जैसे कहा गया कि 160 100 है, हेडेक है और उसमें बाकी चीजें है तो डायरेक्ट सनलाइट या तो सीवियर एक्सपोजर टू सन ये थोड़ा अवॉइड कर देना चाहिए क्योंकि यहाँ पे हमारा ये है कि डायरेक्ट सनलाइट और इसमें पित्त बढ़ता है और पित्त और वात की जो चीजें है उन वजह से फिर ये शोथ की प्रक्रिया या तो हाइपरटेंशन की प्रक्रिया बढ़ जाती है। इसलिए डार्क रूम हम लोग एडवाइस करते हैं। अब जो कि 160/100 ब्लड प्रेशर है हम लोग ट्रीटमेंट के साथ में उसे डार्क रूम में विथ बेड रेस्ट ऑब्जर्व करने वाले हैं। ऑब्जर्व करने के बाद में कुछ आयुर्वेदिक जो रेमेडीज कही गई कि जैसे कहते हैं कि पुनर्नवा जो है, पुनर्नवा यानी बोवे यानी डिफ्यूजा, तो उसका जो क्वाथ है कषाय जो है वो बना के दे सकते हैं, उसका आसव उसके साथ में दे सकते हैं। पुनर्नवा मंडूर कह के कहा है कि इसमें आयन कंटेंट भी आता है और पुनर्नवा भी आता है, उसको हम लोग दे सकते हैं। एक स्पेशली गर्भिणी शोथर काढ़ा कहा गया है कि जिसमें देवदार पुनर्नवा शुंठी हरितकी का चूर्ण जो है वो हम लोग दे सकते हैं। तो बेसिकली ये जो ट्रीटमेंट कह रहा हूँ, या जो रावल्फिया सर्पेंटिना है जिसे हम लोग सर्पगंधा योग कहते हैं या तो सर्पगंधा वटी कहते हैं, तो ये भी इसके साथ में जो लैबेट के साथ में हम लोगों ने देना चाहिए। प्री रिक्विजिट मैं स्ट्रिक्टली कहूंगा कि इन चीजों में डेयर ना करे, क्योंकि इसमें आपके पीछे आईसीयू का सेटअप चाहिए, क्योंकि अगर उसमें एक्लाम्सिया शुरू हो गया तो उसके सीजर के कॉम्प्लिकेशंस जो है आपको इंट्यूबेशन तक लेके जा सकते हैं, तो वो फैसिलिटी आपके यहाँ में चाहिए। ब्लीडिंग डिसऑर्डर अगर होती है तो नियर बाय आपके ब्लड बैंक चाहिए, और अगर आपको इमरजेंसी ओटी प्रोसीजर करनी पड़ती है तो ओटी भी चाहिए। तो आपके सेटअप में अगर आयुर्वेद कॉलेज है या तो हॉस्पिटल है, तो आपके सेटअप में नियर आईसीयू का सेटअप या तो आईसीयू जैसी कुछ तैयारी है, ब्लड बैंक नियर बाय या तो इन हाउस है या तो ओटी प्रेजेंट है, तो ऐसे पेशेंट को डार्क रूम में रख के एड ऑन थेरेपी देके आप उसे देख सकते हैं। अदरवाइज इट इज बेटर टू शिफ्ट द पेशेंट टू टर्शियरी केयर सेंटर। अब इसमें हम लोग सर्पगंधावटी और पुनर्नवा का यूज कर सकते हैं। ये यूज करने के समय हम लोग उसमें जो भी मॉडर्न मेडिसिन कहे गए जैसे लेबेटोलॉल वगैरह वो भी दे सकते हैं, और पेशेंट को हम लोग सर ने जैसे कहा उस तरह से मॉनिटर 100% करेंगे। अगर इसमें स्टेबिलिटी आती है या तो डिक्रीज इन हाइपरटेंशन आता है तो विल कंटिन्यू विद द ट्रीटमेंट। और सिम्टोमेटिक अदर कोई अगर साइन सिम्टम्स मिलते हैं तो उसमें हम लोग अलग अलग टाइप की रेमेडीज जो कही गई है वो हम लोग उसमें यहाँ पे इस्तेमाल कर सकते हैं। तो डायूरेटिक्स देने हैं, और हमारे यहाँ रक्तवस स्रोतस कहा गया है कि जिसमें स्प्लीन आती है, लिवर आता है, और कुछ किसी हद तक हार्ट का भी इन्वॉल्वमेंट उसमें दिखता है। तो इनको प्रोटेक्टिव ऐसे जो ड्रग कहे गए उन ड्रग का इस्तेमाल हम लोग उसमें दे सकते हैं। बेसिकली गोक्षुर एक कहा गया है हमारे रूटीन इसमें ये जो प्रेग्नेंट वुमन है वो उसमें प्रेगनेंसी में कॉम्प्लिकेशंस ना आए इसलिए प्रिवेंटिव करके एक उसने थ्रू आउट प्रेगनेंसी क्या करना चाहिए इसके ऊपर कुछ बातें लिखी गई है, हम लोग उसे ही गर्भिणी परिचर्या करके कहते हैं। तो ये ध्यान में लेके रखते हुए यहाँ पे हमारे आयुष डायरेक्टर सर और आयुक्त सर ने अभी जो जन जागृति अभियान चलाया है एमएचएस के कोलैबोरेशन में, तो उसमें गर्भिणी परिचर्या ये भी एक टॉपिक इसीलिए इंक्लूड किया है कि दो फर्दर कॉम्प्लिकेशंस जो है या तो अगर अलग फिजियोपैथोलॉजिकल कंडीशंस जो निर्माण होते वो ना हो, इसलिए परिचर्या में जो जो चीजें कही गई है तो उनका इस्तेमाल भी इसमें कर सकते हैं। तो इसमें 7th मंथ में गोक्षुर सिद्ध यानी जो ट्रिबुलस टेरिस्टिस ड्रग है उसका इस्तेमाल करने को बोला है। तो ये हिपेटोप्रोटेक्टिव भी है और डायूरेसिस भी करता है। हमारे इसमें इसे क्लेदनाशक भी कहते हैं। तो ये इसका यूज जो है वो चूर्ण के तौर पे या तो कल्प में उसकी वटी बना के हम लोग दे सकते हैं। रेडी प्रिपरेशंस मार्केट में सारे के सारे इसमें अवेलेबल है, तो ये हम लोग उसके ऊपर इस्तेमाल कर सकते हैं। तो की पॉइंट्स इसमें ये है कि गर्भ को हमारे शास्त्र में एक शल्य कहा गया है, तो ये शल्य जब तक शरीर में है तब तक ये डिसीज रहने वाला है। अगर साइड बाय साइड कॉम्प्लिकेशन हमें नष्ट करने हैं तो उसमें हमें एड ऑन थेरेपी में जैसे मैंने कहा पुनर्नवा है, गोक्षुर है, तो शुंठी हरितकी और देवदार का चूर्ण है, तो इन चीजों को भी हमें इस्तेमाल करना है। लेकिन सबसे पहले कहा गया है कि निदान परिवर्जन, इमोशनल स्ट्रेस है तो उसे हमें एश्योर करना है, उसे हमें पूरे तरह से मेंटल स्ट्रेस फ्री करना है। उसके बाद में डार्क रूम में उसे रखना है, एक एड ऑन थेरेपी के तौर पे आयुर्वेदिक ड्रग का इस्तेमाल करना है। अगर फिर भी 2 या 3 दिन में अगर ये साइन सिम्टम्स कम नहीं होते, ब्लड प्रेशर कंट्रोल में नहीं आता है और लैब इन्वेस्टिगेशन में जैसे सर ने कहा कि एलिवेटेड लिवर एंजाइम्स वगैरह हमें दिखने को मिलते हैं, तो इट्स बेटर टू शिफ्ट द पेशेंट इन टर्शियरी केयर सेंटर अगर आपके पास में आईसीयू ब्लड बैंक ओटी नहीं है तो। Otherwise, we may continue this pregnancy as sir told, hand in hand with modern drugs and Ayurvedic remedies. So it's all from my side. Thank you very much, Dr. Karle madam, for inviting me to
Thank you, sir.
express my feelings.
Dr. Darvi, sir, but there are some limitations to treat severe symptoms of
Yes, ma'am.
preeclampsia, but we can prefer add-on therapy, right?
Yes, ma'am. Yes,
So much.
definitely.
Stay with us. Now to discuss homeopathic part, we have Dr. Sonia Parmar. She is Associate Professor, OBGY, Solan Homeopathic Medical College, Kumarhatti. Dr. Sonia?
Yes, good evening, ma'am.
Good evening.
Thank you to MUHS. Good evening to everyone present here.
Good evening, ma'am.
Homeopathic physicians. Yes, good evening. Homeopathic physicians are the first contact physicians for the people, and they are responsible for providing quality services as their allopathic and Ayurvedic counterparts. Homeopathy has a distinct advantage for the treatment of health-related problems of women during pregnancy and in their postnatal period. Homeopathy therapy is safe, effective, and economical. Homeopathic therapeutics, it includes characteristic physical and mental generals and the particular symptoms related to the disease. This has been done to emphasize upon individualization and holistic approach of homeopathy, which forms the fundamental basis of prescription. So as Dr. Anchal has shared a case on preeclampsia, Dr. Anchal, are you present?
Dr. Achal?
Dr. Anchal?
Please unmute yourself.
Yes, ma'am. Yes, ma'am. I'm present here.
Yes. So you are also a homeopath, right?
Yes, ma'am.
Yeah. So how homeopathy helps in antenatal period? It relieves all the existing ailments. It prevents aggravation of systemic disease.
We are eager to see you.
Yeah. Okay, ma'am.
Hello.
Turn on your video, please.
Yes, ma'am.
Yes, Dr. Anchal, please. We are discussing it with you.
Yes, ma'am.
Yeah. So you are in homeopath, right? So
Yes,
as
ma'am.
you know, yeah, homeopathic medicines are very good during pregnancy. It relieves all the existing ailments. It prevents all the aggravation of systemic disease. It facilitates easy and safe delivery. It leaves no deleterious effect on the mother and the child. And it also prevents constitutional dyscrasias, right? So the complications of women during pregnancy, we are going to discuss that is preeclampsia condition. So what is the first thing you will do when a woman is coming to you? She is pregnant and she is having a BP more than, you can say, 140 or 150 by 90 mm of Hg. First thing, you are going to assess the gestational age, right? When you assess the gestational age, if it is less than 20 weeks, so 3 questions aa sakte hain. It can be a chronic hypertension case, it can be a vesicular mole case, it can be a multiple pregnancy. If it is a vesicular mole or multiple pregnancy, please refer it to the obstetrician, right? To the allopaths. And if it is a chronic hypertension, it can be mild, it can be moderate, it can be severe. And if it is a severe type, again, you have to refer the patient to the obstetrician. So we have certain limitations. We can deal with the patients. If you find a patient, if she's having a BP more than 140 by 90 mm of Hg and her gestational age is more than 20 weeks, you have 2 things which comes in your mind. That is gestational hypertension, or it can be a preeclampsia condition, right? Then you see what is the severity of the case, whether this preeclampsia is mild, moderate, or severe. If it is mild, so what are the things will you recommend? Along with homeopathic medicines, we are going to recommend general management. That is, you're going to tell her bed rest. You're going to tell her not to take any extra fluids. Intake or output pe aapne dhyan rakhna hai. Next, you have to tell her to avoid all the salt containing items or foods such as pickles, पापड़, चटनी नहीं लेना है, एक्स्ट्रा सॉल्ट नहीं ऐड करनी है, और उसी के साथ में आपने appropriate management करना है. And if the condition of preeclampsia is very severe, then you have to refer the patient again to the obstetrician, right? Now, there are certain homeopathic medicines which can be given for the treatment of preeclampsia. Can you tell me? Can you suggest any medicines which you have read?
Natrum more sepia carbovich.
नो उससे भी ज्यादा थेरेपेटिकली, जो थेरेपेटिकली इंडिकेटेड है मेंटल और फिजिकल जनरल्स के हिसाब से, मोस्ट कॉमनली थेरेपेटिक मेडिसिन इज एपिस्मेल, दैट इज एपिस्मेलिफिका. उसमें इन्फ्लेमेशन होता है, हाइपरेमिया ऑफ एवरी पार्ट्स होते हैं, इडीमा लोकल एंड जनरलाइज्ड विदाउट थर्स्ट, देयर इज बर्निंग स्टिंगिंग सोर पेन्स, देयर इज ड्रॉप्सी ऑफ लोअर एक्सट्रीमिटीज ऑफ फेस एंड ascites, eyelids are swollen red, edematous, especially the lower lids. There's sensation in toes and foot as if it is too large. Closed rooms are perfectly intolerable to the patient. And there can be, if the, you can say BP is not controlled, fits are also found in pregnancy in epismellifica medicines. So we are discussing about the therapeutic management. What are the homeopathic medicines which are given to the patient who are having preeclampsia condition? Second medicine we have, that is belladonna. It is suited to those patients who are having a furious delirium with burning heat of body, and there is open staring immovable eyes with pupils are dilated, throbbing of arteries and neck with visible pulsation. Next, there is very intense throbbing headache with spasm of the facial muscles. There is visual hallucinations, violent palpitations, urine is turby and it is scanty. So second medicine which we can give for preeclampsia patient in homeopathy after Apis mellifica is belladonna. The third medicine which comes, that is gelsemium. In gelsemium, there is drooping of eyelids, there is excessive flow of blood to the brain and spinal cord, there is dullness, dizziness, drowsiness, which is the characteristic feature of gelsemium. There is lack of muscular coordination, muscles refuse to obey the orders, there is chilliness of the spine. All these are seen in gelsemium. The next medicine for throbbing headache, very good medicine which can be given to preeclampsia female, that is glonine. There is severe headache which starts in the occiput and goes to forehead. There's sensation to jump out from the window. Every motion is painful and the patient lies in the same position. There is a feeling of congestion in the head and dizziness. Their blood seems to rush to heat and throbbing carotids. There is violent convulsions associated with cerebral congestion. All these complaints are present in glonine. We also have medicines such as, if the patient you can say, if they complain of, if the preeclampsia is not controlled, the patient can go into eclampsia condition. There are tonic and clonic convulsions. For that, we can give medicines, that is huperamate hai, auramate medicines hai. And if there is a underlying kidney failure or kidney disease, you can give medicine that is terebinthina. Along with homeopathic medicines, there are also certain Indian drugs which can be given to treat preeclampsia conditions. So, according to me, the homeopaths, Ayurveda, and the allopathy practitioners, they should come together in such a scenario so that they can exchange their knowledge, and everyone should know their limitations. कहाँ हम हमारी मेडिसिन्स दे सकते हैं, कहाँ एलोपैथ्स की हमें जरूरत पड़ सकती है, कहाँ उनका नॉलेज हम अप्लाई कर सकते हैं अपनी प्रैक्टिस में. एंड there should be approach should be in three steps. First approach, we can give homeopathic medicines when the condition is stable. Second approach should be, we can give homeopathic medicine along with the consultation of the allopathic doctors. Third approach is to refer the patient. We should know when we should refer the patient. So in the conditions of preeclampsia, where there is high BP along with edema, along with proteinuria, but if the condition is very severe, if she is having an epigastric pain, if she is going towards tonic and clonic convulsions, we have to immediately, without any thought, we have to refer the patient to the obstetrician. So homeopathic therapeutics, it includes characteristic mental and physical generals and particular symptoms of the patient which are related to the disease. This has been done to emphasize upon the individualization and the holistic approach and the fundamental basis of prescription. So every pathy has their limitations. Every pathy, they should work in collaboration. We should have all these three types of approach, whether to refer the patient or whether you're going to keep the patient with you. So if you know the pathology behind the disease, then only you are going to decide whether this disease is a mild type, it is a, you can say, moderate type or severe type. So assessment of the gestational age during pregnancy is very important to see what is the cause of hypertension in pregnancy. If it is below 18 weeks, and if it is a case of chronic hypertension, if it is a case of vesicular mole, or if it is a case of multiple pregnancy, you have to definitely refer the patient to the obstetrician, to our allopathy counterpart. But if the female is having a preeclampsia condition, if it is, you can say, edema and proteinuria is found, and she is above 18 weeks of pregnancy, we have to rule out whether it is a gestational hypertension or preeclampsia. Then we have to see whether this preeclampsia is mild, moderate, or severe. If it is a mild and moderate, you can keep the patient with you, and along with homeopathic medicines such as Apis mellifica can be given, Mercor can be given, China can be given, Auromate can be given, Helonius can be given, Terebinthina can be given, Glonine can be given, Sepia, Epocinum, Belladonna. They give very good results in the cases of the patients who are suffering from mild and moderate type of preeclampsia. So this collaboration is very important. We have to collaborate with all our allopathic counterparts in order to treat the patient. And this is the approach which is done by MUHS University. I'm thankful. Thank you, ma'am.
Yeah, that's why the meetings are arranged for this interdisciplinary approach to treat each and every condition. So now the case is open for discussion. If anybody wants to ask queries, here are our experts, can ask directly. Is there anything? Okay, there is feedback link in chat box. Please click and give your feedback. Okay, and please suggest next topics. Dr. Seema?
Yes, madam.
Want to add something?
No, it's a good, means you have started a good CME, regular CMEs, means at least once in a month, and topics are
Yeah,
also
it is
good.
twice a month, first and third Wednesday of each month. Okay?
And I don't want to give any suggestion. All pathies you are mixed, that I like so much. And topics, you can add diabetes and mostly lifestyle disorders also in this, means
Okay.
apart from ANC.
Lifestyle disorders. Okay.
Thank you, ma'am.
I had a question. Why bed rest? Can you repeat again? In preeclampsia?
Question for whom? For all. Okay.
Okay, can I answer this question?
Yes, sir. Please.
Okay. So first of all, bed rest is advised, and now it's a evidence-based study has shown the benefits of bed rest through effective venous return. Okay, so in preeclampsia, because of the vasospasm at endothelial level, the changes starts happening and it starts giving, hypertension is seen. So effective venous return is compromised, and that's why bed rest helps in those conditions. Apart from that, yes, if you keep patient ambulatory, then the amount of physical exertion, the physical exertion, that will also lead to various complications like rise in blood pressure. Sometimes patient may have a sudden detachment of placenta through uterine bed, that is called as abruption also. Visual disturbances which are due to the retinal hemorrhages or cerebral edema, those are also seen to be increased during ambulatory phase. Okay, so these are the things which can be prevented through bed rest. That's why we ask patients to take bed rest. But of course, we can't keep patient non-ambulatory or bedridden for 24/7. Of course, there is a risk of deep vein thrombosis is there. We have to keep the DVD stockings intact, or sometimes we also provide few compression equipments are available nowadays to avoid deep vein thrombosis to these patients. The second part is, it is very easy to monitor these patients when they are hospitalized. If you keep them if you keep follow up on OPD basis for severe when severe preeclampsia is there, then it would be difficult for us to go through the progress of the disease. That's why initial stages you need to hospitalize patient, monitor them closely, and under supervision you may diagnose the condition, and management part can be very well decided.
Okay. Thank you, sir. So there is another question in chat box. What will be homeopath choice if drug for PIH? Its potency and repetitions is for Sonia ma'am. Unmute yourself.
The drug of choice depends upon symptom similarity, and mostly 30 potency medicines are given in preeclampsia condition. 30 potency.
Okay.
Not frequently repeated, but not frequently repeated. Yeah. But along with homeopathic medicine, it is very important. General management is very important. You give the medicines, but if the patient don't rest, don't control their diet, for example, extra salt intake also should not be there. Monitoring of input and output also must be recorded. So this is very important. Along with homeopathic medicines, appropriate homeopathic medicines, general management is also very important.
Thank you. So I think we should stop now. Thank you so much, Dr. Achal, for nice case presentation. Dr. Sandeep, Dr. Prashant Rahisa, Dr. Sonia, thank you so much. And thanks to all participants for interactive session and careful listening. Thank you.
Yes, good presentation, good case presentation, Dr. Achal.
Thank
yes.
you.
Thank you, Gitanjali ma'am, for inviting. It was a wonderful session. Yes, we also came to know so many things are there in Ayurveda and homeopathy. So thanks for elaborating those important things. And of course, students will get the message that there are so many things available. We can utilize various modalities. Thank you.
Yes, sir. Yeah.
Thank you very much, Vandana.
Thank you.
Okay, thank you, ma'am. Bye.
Bye.